the scrotum. So it was presented by Dr. Patrick Lungu and facilitated by Dr. Lunga. Just a brief of the statistics, very brief. It was discussed that urogenital TB, the third most common form of EPTB, that's extrapulmonary TB, and accounts for about 20 to 30% of pulmonary TB cases. So the burden for this proto-TB in Zambia is not known as of now. And the reason could be due to low index of suspicion from healthcare workers and challenges faced in diagnosing the EPTB. So the take-home points were urogenital TB is very common, but diagnosis is often. This is, as I explained earlier, there's lack of clinical awareness among the healthcare workers, and it really needs thorough history taking and thorough history examination. And then the other reason could be the patient's presentation is not very specific when they present with this. Therefore, there's needs to have a combination of high index of suspicion, good clinical history and physical examination. Good laboratory investigations are definitely required for one to have a good diagnosis of EPTB. So the main treatment for EPTB is mainly ATT, but depending on the patient's presentation, surgery may be needed. Thank you very much. That was just a quick recap. Over to you, Dr. Ziambo.
Thank you very much. And I was reminded of a number of things from that recap. Thank you very much. I've forgotten. That is actually the third commonest presentation in extrapulmonary TB. So there's actually a need for each one of us to have a very high index of suspicion when it comes to tuberculosis affecting testes. So today we'll continue with our session for today. I forgot to mention, to introduce another person that is important in this session. We also have Dr. Manzi from Maternal General Hospital, who actually has put together the presentation that we're having this afternoon in terms of a case as an example, and then also just to help them with some of the questions that they're asking there. So thank you so much, Dr. Manzi, for joining us. So at this particular time, as we bring up the slides, I'm going to invite Dr. Mulenga just to introduce herself, and then we'll be able to take us through this afternoon's session. Dr. Mulenga.
Good afternoon, everyone, and welcome to this session under the PMTC program. My name, as has been mentioned, is Priscilla Mulenga. In short, you can just address me as Dr. Priscilla. So I'm going to talk about HIV syphilis dual test, and I will also emphasize on maternal syphilis management. Thank you.
Yes, so apologies for that. We'll try and just change the presentation. Haiti, could you help? Is that okay? So just hold on a bit. We'll try and reshare slides. Oh. So thank you so much, Janet. We're sorry about that. I hope we can see a full presentation now. And we'll ask Dr. Mulenga to pick it up. Thank you very much, Dr. Mulenga.
Thank you very much, Dr. Ziambo. I've already introduced myself. Just address me as Dr. Priscilla. I am the PMTCT Program National Coordinator. I've mentioned the title of my presentation. It's on HIV syphilis dual testing, and also maternal syphilis management. So on the screen, we have the objectives for this presentation. We are going to share with you the goal of the PMTCT program. Most of you may not be aware of what the program is all about, what the program is up to. We are going to explain the rationale of the EMTCT strategy. Basically, EMTCT is elimination of mother-to-child transmission of HIV and also syphilis, because we are looking at the dual, and we are going to outline HIV and syphilis in pregnancy. We'll describe the dual HIV syphilis testing, and we'll discuss the management of maternal syphilis. So those are our objectives.
Okay, so we can move on to our first poll. And we would like to invite everyone to participate in this session. So you will launch the poll, and then you can just click which one is true or false. So globally, the mother-to-child transmission of HIV does not contribute significantly to HIV pandemic. Globally, the mother-to-child transmission of HIV does not contribute significantly to the HIV pandemic. True or false? Very interesting question. So we have 300 or so people that have joined in, and we're hoping that we can all participate in the polling. And so far, about 48% have voted. That is half of those that have joined in. Globally, the mother-to-child transmission of HIV does not contribute significantly to HIV pandemic. We'll give you another 10 more seconds, then we can move on to the next slides. So far, most people think it's a false statement. There's good participation today, about 65% have done the poll. Okay, so I will end the poll. Thank you very much for participating. I'll end the poll. So that's how we have polled. Most people think that it's a false statement. So these are the results. Okay, so we can move on to the next slides.
Yeah, thank you very much, Dr. Kozia. First and foremost, it's important to know why the program exists. So the background is that more than 95% of pediatric HIV infections are through mother-to-child transmission of HIV. So it then follows that if we eliminate mother-to-child transmission of HIV, it is possible for us to have a generation of children free of HIV infection. The program goal, the slide has moved fast, but the program goal is that as at now, we need to eliminate mother-to-child transmission of both HIV and syphilis. So this is what we refer to as dual EMTCT, because we are targeting elimination of mother-to-child transmission of two diseases, HIV and syphilis. So this chart is just showing us some global HIV and syphilis data during pregnancy. The first row there, we have a pregnant woman, and the data is that we have about 1.4 million pregnant women, and this data was taken in, it represents 2019, sorry. And then syphilis, we have 908,000 infections every year. In the mother-to-child transmission, for HIV, we know that without intervention, the risk transmission is between 15 to 45%. We know transmission can occur during pregnancy, it can occur around delivery, and it can occur during breastfeeding period. Much of the infection occurs perinatally. For syphilis, without intervention, 52% of transmissions do occur. And for the infants, for 2019, we have the statistics there of 150,000 children who were infected, and then for syphilis, 661,000 infants actually got congenital, but this had adverse outcomes from maternal syphilis. So the question is, why are we emphasizing on the dual EMTCT strategy? Okay, we should bear in mind that we are a resource-constrained country, so we need to use resources prudently. First and foremost, the mother-to-child transmission of HIV is a significant contributor. It's not something that we should neglect, because it's a significant contributor to the HIV pandemic. We need to manage the MTCT if we have to attain the goal of the HIV program, which is to end AIDS by 2030. So MTCT accounts for 9% of infections globally. So it's up to you to tell whether it's significant or not, but to me, it is. Then mother-to-child transmission of HIV is much more likely among pregnant women with syphilis. That's one of the reasons we are bringing in syphilis. HIV and syphilis are both vertically transmitted diseases, and both cause adverse birth outcomes. And syphilis is the second most common cause of stillbirth in the world. Just to remind you, malaria is the first. Yes, we have reduced the incidence of malaria, but you should still remember that it's the first common cause of a stillbirth, followed by syphilis. So actually, we do have data, and this data was generated in our neighboring country in Malawi. A woman with HIV and syphilis is actually 2.5 times more likely to transmit HIV to her child than a woman who does not have syphilis. So it's important that we screen for syphilis and we treat those who test positive. Those who are still reactive. Syphilis still affects. Okay, by still, it's because we've had syphilis since time immemorial. Because some of us were born, syphilis has been there, and the treatment is known. Okay, but it's still affecting large numbers of pregnant women worldwide, as highlighted by the following WHO estimates. In 2008, 1.4 million pregnant women around the world were infected with syphilis, and 80% of whom had attended antenatal care services. We are emphasizing syphilis screening because we've had missed opportunities. Women come to the ANC, but we are not screening. If we don't screen, then we will not be able to even manage the syphilis. The other statistic is that 1 million pregnant women per year have syphilis. Okay? So syphilis is quite causing a burden in our pregnant women in ANC. We need to screen. Then untreated maternal syphilis results in transmission to the infant in up to 80% of cases with resultant significant adverse birth outcomes in 52% of cases. We have seen that without intervention, 52% will transmit. And that is also just some adverse effect, highlighting on the adverse effects. An estimated 350,000 adverse pregnancy outcomes occur worldwide. And in 2012, that was the distribution of syphilis. 143 of syphilis birth outcomes, 143,080 fetal deaths, 62,000 neonatal deaths, and 44,000 preterm, 102,000 infected infants. Occurrence of adverse birth outcomes signals a failure of both syphilis detection mechanisms and also prenatal care system. So preventable maternal syphilis can be screened and the woman treated, and this can prevent all these adverse birth outcomes. So syphilis treatment and testing and treatment must be a part of comprehensive PMTCT program. I guess by now you have picked my message. Syphilis treatment and screening in ANC is critical for us to prevent these adverse birth outcomes. So globally, there has been marked progress towards eliminating mother-to-child transmission of HIV, but progress is much slower regarding syphilis. We seem to be doing fine on the HIV front, but with the syphilis, we seem to be struggling. Remember, it's a dual EMTCT. And Zambia has joined other countries in the region and also globally to ensure that we eliminate HIV and syphilis. And is committed to the integrated and harmonized dual approach because it serves to improve broad range of maternal and child services and outcomes. So an integrated approach is necessary to improve efficiency and quality of MCH services. It offers women more comprehensive primary care, and ultimately it reduces preventable adverse birth outcomes. So those birth outcomes, what we should have in mind is that those are lives that are being lost. Yes, so as we implement the dual EMTCT, elimination of mother-to-child transmission for both HIV and syphilis, we do have the indicators that we follow, and also the indicators that will determine whether we have attained our goal. So here I have just highlighted what we call the process indicators. These are the indicators that we are following to see whether we are moving in the right direction. So we have the ANC1 coverage for both HIV and syphilis. We have the HIV testing coverage for pregnant women. We also have antiretroviral therapy coverage for HIV-infected pregnant women, and syphilis testing coverage for pregnant women, and adequate, what we call adequate treatment of syphilis, seroreactive pregnant women. And the indicators are shown there. Okay. So for the attendance from 2019, 2020, 2021, we seem to be doing fairly well. And that 102, of course, most of you understand is because of the population-based estimates that we use from now Zamstat. Otherwise, the target is supposed to be 95. So for the attendance, okay, most of our women are actually reporting for ANC, the first ANC, and it's important that we encourage these women to actually attend in the first trimester. Okay. The second one on testing for HIV, relatively fine, but we still need more. We had 94% in 2019. We dropped to 2020, in 2020 to 87. And as of last year, we were at 93. So this is from country level. And the ART therapy, the statistics are as shown on the screen. So I want to you to pay attention to the syphilis data. So when you compare to HIV, it's clear that we are struggling with syphilis. In 2019, the testing was at 54. In 2020, we dropped to 48. Then in 2021, we dropped further to 44. Then also for treatment, we did fairly well in 2019 at 86%. And in 2020, we dropped to 73. And in 2021, I've put it in red because I'm not sure whether this is a true reflection, but this is what I got from the system, or it's a data issue. We dropped to 6%. So we have issues with syphilis screening and also treatment. Yeah.
Oh, thank you very much. Very informative so far. And we just want to invite the network now to also participate by way of pause. So I've launched the second poll. And so inviting you to just make a choice. Standard diagnostic violent test is currently used as screening test for HIV syphilis dual test in Zambia. Standard diagnostics violent tests is currently used as a screening test for the HIV dual test in Zambia. True or false? Okay, great. Thank you. I can see a lot of participation. Thank you, everyone, for joining. Is this a true statement or false statement? Kindly pick the best answer. Okay, so let me just end the poll. So we seem to have a tie. 50-50. 50 think it's true and 50% think it's false. Let's see how that goes. Thank you everyone for participating. So you can see here that's 50-50. So Dr. Mulenga, you have some explaining here for us to do.
Yes.
Please go ahead.
So I assume we all know the positive organism for syphilis. I will not delve into that. I've just started at the stages of syphilis infection. And this slide is important because it guides the management of syphilis. So treatment of syphilis is dependent on the stage. Let's remind ourselves of the stages of syphilis. We know that the incubation period is from 10 to 90 days, and on average is 3 weeks. Okay? So syphilis has about 4 stages. The first stage is the primary syphilis. This occurs 3 weeks post-infection, and it lasts for about 3 to 6 weeks. Okay. The second stage is secondary syphilis, and here 25% of untreated primary progresses to this stage 6 weeks to 6 months post-infection, and this may last from 2 weeks to 6 weeks. So primary and secondary syphilis, these stages are usually referred to as early infection, and these would usually occur within 2 years. Someone with the early infection syphilis, they are quite contagious. Then we move on to the latent syphilis. And let me also make mention that latent syphilis is divided into 2. We have the early latent and also the late latent. This stage is reached when primary or secondary syphilis is not treated. And the last stage is tertiary syphilis, and this comprises 30% of untreated secondary syphilis, and it occurs 10 to 30 years after initial infection. So latent and tertiary syphilis, actually latent and secondary and tertiary syphilis are regarded as late infection, and they are not as contagious as the early infection, and they usually occur after 2 years. Important to understand this slide because it's critical when it comes to management.
Thank you for that emphasis.
I think much of this slide actually I have already emphasized, but this is just presented differently. 48% may be born healthy. Then remember the transmission may occur in 52%, and it's broken down like that. Then congenital syphilis. If the pregnancy does not end in stillbirth, congenital syphilis can cause deafness, blindness, deformed bones, severe anemia, skin rashes, encephalitis, and liver dysfunction, okay, which can present as jaundice or enlarged liver. So in Zambia, we had to adopt, okay, we have adopted actually adopting dual testing and strengthening syphilis treatment would ensure at least 200,000 women are tested every year, and this would save 3,000 lives. And you all agree with me that as healthcare workers, we are there to save lives. And this bar diagram is just comparing for 2020, when we had no dual syphilis HIV testing, to when we have dual HIV syphilis testing. You see that the gray bar from my end in 2020, which is neonatal deaths.
Great.
Well, basically is when you focus on the second bar, you find that the gray, which is like healthy babies, the bar will be pushed higher, meaning we'll have more healthy babies. And then those with adverse birth outcomes, the blue one is stillbirths, it will be reduced. if you compare the two, and then followed by the light blue, which is congenital syphilis, and the green neonatal deaths. So basically, we are going to reduce the adverse death outcomes and increase on those that will be born healthy. So this is what we are saying. This was a projection using spectrum and also some reported data from MOH. So this is what a HIV syphilis duo test looks like. So this is a test, a strip that can conduct 2 tests. As you can see there, it's labeled HIV/syphilis. So you have 3 lines there. One is for the control. Control is very important. We all understand why we should have a control there. It shows whether the test will be valid or not. Then we have the syphilis and the HIV. Let me also mention that this is a rapid diagnostic test. Okay, very easy to perform, just the way we perform our usual HIV tests.
All right, thank you very much. Let's share another 4 questions. Okay. So this is for question number 3. After undergoing an HIV syphilis dual test at her first antenatal contact, Kuswepo Chansa from Kasama Bangweulu Clinic, in Zambia is negative for both HIV and syphilis. The following are key messages for her. Except she should quickly rush to Mansa General Hospital to confirm her HIV and syphilis status using the NAT nucleic acid test and RPI respectively. Safe sex practices should be emphasized. One tie was part of the testing algorithm used for HIV syphilis. She should be informed of the availability and offered PrEP if eligible. Remember, this is a client going to Kasoma Bangweulu Clinic on their first ANC, and they've tested negative for both HIV and syphilis. Which of the following? The following are key messages for I accept. Another tricky question. So we need to pick which one is an exception here. Following are key messages that we need to tell her, but except one. Which one is it? This question is reminding me of an exam. Okay, so network, please go ahead and call. We have over 400 people that have connected. Thank you everyone for connecting. Hope they're having an important knowledge sharing opportunity. Yeah. Okay, so I'll give 10 more seconds. Okay, so I will end the poll. So far, there's been a fair distribution. Or some people think most people think it's B, which is an exception. Others think it's A, and others think it's D. So stop here and see how it goes as Dr. Priscilla continues. Please, you can pick it up.
Yes, we are now going on to go through the HIV syphilis duo algorithm. It looks quite complicated, but it is not. Okay, let me assure you from the start. Okay. It looks, the slide is busy. but it's easy to follow through. So let's start with determine the first thing when you are using the HIV syphilis reward, you need to determine whether the recipient of care was previously tested for HIV. Why do we have to do this? It's because the dual tests, they need to be used in those with unknown HIV status and also unknown syphilis status. If one knows the status for either HIV and syphilis, dual tests are not recommended. We only use them for those with unknown HIV status and also unknown syphilis status. So once you have determined, if the answer is yes, you determine the client's HIV status. If it was negative, then you need to determine how long ago the recipient of care was tested. And if it's less than 3 months, you need to test for syphilis only. So let's get back to determining the recipient of care HIV status. When we discover it's HIV positive, we do not need to do an HIV syphilis testing on this person. We only need to do a test for syphilis only because they already know their HIV status. So we need to use a rapid syphilis test. So when you go down, after you have used the rapid syphilis test, if it's positive, you have a signal there that you need to stop. So that signal or that sign is showing you that there's an action point. You need to cancel the recipient of care on positive syphilis diagnosis and treat, okay, actually recommended the same day with the benzathine penicillin 2.4 mega units, okay, IM. It's important also to find out, to inquire from the recipient of care whether they are allergic to any penicillin or not, because there's still a risk, though minor, of allergic reactions to penicillin. After that, you confirm syphilis diagnosis with RPR. If not available, you collect specimen and send to nearest facility, RPR. Why are we emphasizing? It's because we need to determine the staging. If latent syphilis is detected via RPR, treat with second and third doses of benzathine penicillin each week, each 1 week apart. We can get back to where the syphilis is negative, just using the RIST. If it's negative, you cancel client on negative results for syphilis. We can now get back to after determining the recipient of care's status, HIV status. If they do not know or if they have not been tested, you determine if the recipient of care has been tested for syphilis in the course of their current pregnancy. If they say no, you again test for HIV. You then test for HIV, okay? let me just get back. Okay, you determine that this person has not tested for HIV. And also, they have not tested for syphilis. So this woman is then eligible for the dual testing. So you test this woman for HIV and also syphilis using the HIV syphilis dual test. If the HIV is negative and the syphilis is also negative, you cancel client or cancel the recipient of care on negative results for HIV and syphilis. Remember to repeat testing in 3 months for HIV. We go on the other end where the syphilis is positive. The action there is to cancel client on positive syphilis diagnosis. Again, you treat same day as you did for any syphilis seroreactive woman. So the take-home message here is that, okay, only use the HIV syphilis duo for those women and their partners. They're including partners in this. So it's pregnant women and their partners who do not know both their HIV and their syphilis status. Okay. Let me also make mention that for the dual test that we have currently, we are using the SD BioLine for screening. Interesting, eh? We are using the SD BioLine for screening for HIV, and for confirmatory, we are using the one time. So a syphilis rapid test, okay, either the single or dual, identifies whether someone has antibodies to syphilis, okay, which remain in the blood even after someone has been successfully treated. So using a rapid test, what we are using in the facility at the point of service delivery, it will not say whether the infection is early, is late, or previously treated. You need to understand and appreciate this. A rapid test will not tell you whether the infection is early, late, or this woman was previously treated. Therefore, we are emphasizing on collecting the specimen and take to the nearest center with a lab where an RPR can be done. So if a pregnant woman is positive for syphilis, okay, on a rapid test, immediately, okay, we should not miss the opportunity of treatment, because just one single dose is adequate to prevent mother-to-child transmission. So immediately, when a woman tests positive for syphilis on a rapid test, you treat with 2.5, a single dose, benzathine penicillin, unless she's allergic, because the risk of an adverse event warrants extra care. After she receives the first dose, okay, of benzathine penicillin, a rapid RPR test should be done to determine the stage of disease. So here on the transferring samples, we already have systems in the facility, and we are not sending to central labs. We are sending within the district, the nearby. And most for facilities with labs, we need to ensure that we are able to test for syphilis. And then when you send for syphilis, ask for the titers, because it's the titers that we are interested in. so that we can determine whether this woman should be given the second and the third dose. Otherwise, to prevent mother-to-child transmission, 1 dose is what is referred to as adequate. But remember, we are also looking at this woman. Okay, we do not want to poorly manage this woman. So if this woman has late syphilis, we will need to do the RPR, the RPR titers, and this is how the explanation is. I am not a lab person, but I'm being supported by colleagues from the lab. So if the titer is less than, the ratio is 1:8, it indicates early syphilis. And if you remember when I was taking you through the stages, we said early syphilis is very contagious and we need to treat. Then if the titer is, the ratio is more than or equal to 1:8, it shows latent syphilis. And if it's less than or equal to 1:4, this one is an indication that there was previous treatment. So important that our colleagues from the lab in the facilities, they should be able to do these titers. If it is early syphilis, then 1 dose of 2.4 mega units penicillin would be sufficient. If it is latent, remember the 3 doses are required. As it is now, we are actually overtreating these women because traditionally and historically, we've been treating syphilis. Everyone who tests positive to a rapid test, we've been treating with 3 doses. Yeah, so remember I started by reminding ourselves that we are very resource constrained. So there's need for us to be prudent with the resources. And we should all reserve the benzathine to those who actually need it. So key points on this is the woman with what? So key points, let me just quickly take you through the key points on the use of HIV syphilis dual test. So pre-test counseling is essential for anyone who is being tested for HIV or syphilis. Just like anyone just being tested, at least you need to do some pre-test counseling. Confirmatory testing for HIV should only be done when the woman is reacting for HIV on the screening test. The screening and confirmatory combinations are HIV syphilis duo and anti-HIV, or on the single one, the one that we are using currently is the determine for screening and SD Bioline for confirmatory. So both HIV tests, screening and confirmatory, must be reactive for someone to be confirmed HIV positive. Then quickly through the counseling, yes, this is just to emphasize that we need to do the counseling properly. The woman should receive adequate counseling. So HIV is transmitted through sexual contact from mother to child and through contact with contaminated blood products. The best way to prevent HIV infection is through safe sex practices. Prevention, prevention, prevention. Early screening and initiation of ART, if found positive for HIV, is the mainstay to protect one's child from contracting HIV during pregnancy, delivery, or during the postnatal period. Retesting every 3 months is critical for someone who is negative for HIV to ensure they are detected early if they become newly infected and the chain of transmission to the child is interrupted. Allow me also to emphasize on this point that most of the breakthrough infections that we are seeing in our infants is from these women who are actually seroconverting. These are women who are already in our care, and we are not doing much in terms of prevention, and they are ending up seroconverting in pregnancy and also during breastfeeding. So let's ensure that we offer these women prevention measures that are available in our facility. Then on syphilis, counseling on syphilis, the messages is also a sexually transmitted infection. To prevent syphilis infection, use safe sex measures. And I'm assuming that we all know what those safe sex measures are. Syphilis oftentimes does not present with visible symptoms. Remember, we have that latent phase. Just like HIV, we do have that kind of latent phase. So testing is the most reliable way of identifying syphilis infection. If syphilis infections in pregnant women go untreated, we've already discussed the adverse birth outcome. An HIV positive woman who also has syphilis, we are saying is 2.5 times more likely to transmit HIV to her child. When to use the HIV syphilis test, I've already alluded to this. The dual test should be used for all pregnant women and partners. Partners, please come on board. Men, we need you, okay? Who have an unknown HIV status or are eligible for retest. Of course, those who are eligible are those who tested 3 months ago, over 3 months ago, and have not been tested for syphilis during the current pregnancy. So only those who do not know their HIV and also syphilis test, pregnant women and their partners. It should not be used for the general population. The dual test is for pregnant women and partners. It is not to be used when screening the general population for HIV or syphilis. So if you want to screen for the general population, please embark on the journey that I embarked on some 2 years ago of resource mobilization. The current stock of the dual test are for my pregnant women, not for the general population.
Message. Okay.
So when to use a syphilis only rapid test? A syphilis only rapid test should be used instead of a dual test when a pregnant woman or partner is non-HIV positive. Don't waste the dual test. Or if they are HIV negative and not eligible for retesting. It is essential to use a rapid test for syphilis rather than a laboratory test where possible, so that the recipient of care can receive results within 15 minutes and access treatment the same day. Then when to use an HIV-only test? An HIV-only rapid test should be used instead of a dual when a pregnant woman or partner was already tested for syphilis during the current pregnancy, or a pregnant woman has reached the postnatal period. If an HIV-only rapid test is to be used for screening, the tests to be used are the same as for the general population. Determine for screening and the BioLine for HIV confirmation. Yeah, in counseling a pregnant woman who is negative for HIV and syphilis, the clinician should ensure she understands and continues to use safe sex practices, understands the importance of repeating testing for HIV throughout her pregnancy and until cessation of breastfeeding at 24 months. She should be encouraged to bring her partner for testing, and where it's available, actually it should be available. She should be offered PrEP, okay, if eligible. Yes, I think much of this I have emphasized on same appointment. You treat for those who are positive for syphilis and benzathine. Okay? Benzathine, penicillin is the preferred treatment for syphilis as long as the pregnant woman is not allergic, as it is highly effective in treating the fetus. The pregnant woman must be encouraged to bring her partner in for testing and treatment. So the last portion is just on treatment. And much of it I have already explained. The first line I've even highlighted in red, okay? For AIDS syphilis, it's benzathine, benzathine, benzathine. One dose for AIDS syphilis. Lead syphilis, benzathine, 3 doses. So you only use 3 doses for benzathine for lead syphilis. Let's also bring in the second line, okay? Yeah, so second line, if you can read what is on in the first column, the third row under the asterisk, should only be used if the recipient of care says she is allergic to penicillin. Yeah, so the alternatives are given. Okay. And then for the macrolides, we have erythromycin and azithromycin. These, they do not cross the placenta to go and treat the fetus. So even if you are giving this woman, just know that the fetus is not benefiting. So use them sparingly, but let's ensure that we do have the benzathine in our facilities. And at our level, we are going to ensure that we also ensure that there's availability of the benzathine penicillin. And do not use the benzathine penicillin for other STIs. It is not as effective. Reserve the benzathine for syphilis. For other STIs, consult the STI guidelines. It is not benzathine. Our next strategy, okay? As at now, we are doing dual, but this year we are transitioning to triple EMTCT. And with that, we are just bringing on board the hepatitis B virus. This is where I end my presentation. Thank you for listening.
Thank you very much, Dr. Mulenga. That's been a very wonderful presentation. A lot of information has come through, and I'm seeing the chat box full of questions. I hope our panel experts have been able to respond to some of the questions. So it was a loaded session, so we may have run out a bit of time. So I'll quickly ask Dr. Manzi, are you ready for a session?
Good afternoon, Dr. Ziambo. Yes, I'm ready.
Thank you so much. We'll share the slides for you. Dr. Manzi, can you see?
Yes, Dr. Ziambo, I can see.
All right, sure. Please go ahead.
Okay, good afternoon, everyone. My name is Manzi Victoria. I'm a medical officer based at Maternal General Hospital. Next slide. Next slide.
Oh, it's coming on. I think it's slow.
Okay, thank you.
Can you see?
The slides are not moving.
Okay, let me just, yeah. that okay?
Yes, Doc. Thank you so much. So I'm presenting a female 26-year-old, a prime gravida at 34 weeks, 4 days gestation by date. She's a non-RVDR patient on ART since August 2020. We received at Maternal General Hospital as a transient from Kamala Clinic in December 2021. Antenatal history, she booked at 13 weeks, 5 days at Maternal General Hospital and has had 3 follow-up visits on the 14th October 2021, 2nd December 2021, and 20th January 2022. Sorry for that, supposed to be 20th January 2022. She tested for syphilis on the 3rd follow-up visit, as the test kits were out of stock during the other visits. She and her partner have received 2 injections of benzathine penicillin. And like I said, she's a non-RVDR patient. She has no history of TB, drug history. She's currently on TLD, Septrin, folic acid, ferrous, and previously she has received isoniazid preventative therapy for latent TB treatment. Socioeconomic history, she's married and she's employed. On the 2nd December, the examination, which was done, reviewed a temperature of 36, a weight of 50 kg. Her blood pressure was 100/77 millimeters of mercury. She was afebrile. She was not pale, not jaundiced, and not cyanosed. The chest was clear, and cardiovascular examination, S1, S2 were tachycardic. Obstetric examination, her abdomen was distended. The height of fundus was 24 centimeters. Lie and position were not defined. Urinalysis, protein and glucose were negative. Next slide. So this is a clinical timeline. Of note that she was commenced on ART on TLD in 2020, and after that, a viral load that was done 6 months later, the results were not received at the facility. A repeat viral load that was done 3 months later, no results. And the latest viral load is in June 2021, which was 0 copies. The HB in September at the time of booking was 13 grams per deciliter. And the latest viral load, which was collected in October, we are still waiting for results, and she's still on TOD. Next slide. Okay, thank you so much. I think that was a presentation. Unless there are clarifications, and these are the questions that we had at the facility.
Thank you so much, Dr. Manzi. And the questions were, how can we ensure that all pregnant women are tested for syphilis at the first antenatal visit? How should the infant of this mother be treated? And should the RPR test be repeated? So when? So we have here a woman, a 26-year-old primey at 34 weeks, the final trimester, who's been on treatment on TLD and tested positive for syphilis. And then the examination is normal. And so the viral load is normal, is well suppressed. So what is the management in terms of how can we ensure that all pregnant women are tested for syphilis at the first antenatal visit? So we'll open it up for discussions from the network. If you have any clarifications to make, please go ahead and ask. Raise your hand. We'll call on your name. Just clarifications before we invite for any comments regarding the questions. Any comments, clarifications? Dr. Manfred Dupia, go ahead. Can unmute? IT will help you unmute. There. Go ahead, Dr. Manfred.
Yes, Dr. Ziambo.
Please.
So, Dr. Ziambo, I think you've been to our facility and you've been helping us. I must mention that. But for the, I think last month up to now, we have in stock the test kits, the dual test kits. And as a facility, we've been suffering in terms of the stocks. Even the ordinary RPR, we don't have the reagents. So that is a screening test that we are supposed to be using. But up to now, we've been told, no, wait. I think even the province, I think they are aware. So I don't know for how long are we going to wait, because we need to use these. And as from the presentation, you saw that the percentage in terms of the performance in syphilis were down. So we can't improve if we can't test now. So otherwise, they will expire, and that will be a lot of money that we'll lose. So we need the guidance as soon as we can.
Thank you very much, Dr. Lupia. Straight to the point. We want to use these things. Thank you very much, Dr. Lupia. We will have a comment on that as we continue to discuss. We just wanted to some comments on the case. So we'll address your concern. I'm sure it's a common concern, as a general concern in most of the facility. So thank you for coming through and just highlighting that challenge to us. Dr. Makelele. You've raised your hand, go ahead. IT, can you help with Dr. Makelele? You raised his hand. He is unable to unmute. Okay. Any other comments?
Okay. Now I'm able to speak.
Please go ahead, Dr. Makelele.
Yeah, it's a good initiative we are in now. But as you said, if the protocol, the SOP is put in place, well elaborated, and displayed explained to all the frontliners. In addition to that, number 2, we avail the commodity, especially commodity management part, because people have excuses not to implement such a program the way that we don't have reagents or we don't have the drugs. Number 3, this is now at supervisory level. How often do we check if we are monitoring our program? Is it a quarterly basis? We are quickly aware of any intervention, any gaps, so that we address it before things come to us. Those are the 3 stages I can suggest for now. Over.
Thank you so much, Dr. Makelele, for those important submissions. And I think they've been taken note of. Yeah. Emmanuel Muliana, I've seen you've raised your hand. I hope you also have a comment on what we're discussing on the case. Please go ahead. Emmanuel? We cannot hear you. I've seen that you have unmuted, but we can't hear what you're saying. Okay, perhaps in the meantime, we'll ask Mercy Bella to kindly unmute yourself and make a comment.
Okay, Thank you very much.
Sorry, Mercy, please unmute yourself. Mercy, we can't hear you, sorry. We lost Mercy. Sorry. Mercy?
Hello? Are you able to hear me now?
Yes.
Okay. So my question is for the
Just turn off your
pregnant woman
device.
who has never attended antenatal clinic, then she comes to labor ward, then you decide to do dual testing, which is HIV test and the syphilis, then it comes out positive for both. What will be the management for this woman and the infant? Thank you.
So, Mercy, you're saying a woman who doesn't know her status
Yes.
comes to the clinic in labor and tests positive for dual test. What's the
Yes.
management plan? Okay. Take a
For
note
both
of-
the mother and the infant.
Okay, thank you very much. We'll take a note of that. It's a similar question to what we have here on our case that we're discussing today. So it's something similar. Dr. Singh, is this Moses Sinkara? You wanted to make a comment as well, and then we'll hear from patients as well. Moses?
Yeah, sure. I want to make a comment. The presentation was good, and it is light focus, but my worry is on the commodity security, and also on the mental, probably I would say the orientation process. So the first part is I'm a lab personnel from Lundazi, DHO, and we haven't seen these commodities trickle down up to smaller facilities up to now. All that we are hearing is dual testing. Secondly, the trainings they haven't been sensitized. They haven't been so much trickled down to lower facilities where these commodities and where mostly these cases would be found. So I don't know what is the focus of what's the focus that we are taking as a team, or whether this should be first implemented in towns like Lusaka. Villages are still on hold. Thank you very much. My submission.
Thank you very much for your passionate appeal, Moses, and thank you for joining us from Lundazi. That's my home village. Thank you very much. A comment from patients. We've taken note of the question. We'll respond in a moment. Patients?
Hello, good afternoon.
Yes, patients.
Can you hear me?
Yes.
Loud and clear.
Oh, thank. Oh,
We can't hear you anymore.
all mothers are tested for syphilis available. As we speak, I'm calling from Mulenga province. I've sampled 3 districts. They don't have these tests. They've been stocked out for the past 3 months, and those which they had then were procured by respective districts. So having been to the antenatal care clinics, if we make this, especially the testing algorithm that Doc took us through, very clear, we ensure that each antenatal clinic has this. And then we make these test kits and sample bottles available within antenatal. It's very possible. I've seen that 80% of the eligible women have been tested for syphilis whenever the test kits are available. What is making our providers not to test?
Sorry, Patience, we've lost you again. I think we've heard most of your message. Thank you very much.
Because the test kits are not available in the lab. We've noted that. Yes, I was saying that sometimes when the stocks are low, we have a tendency of restricting the test kits to the lab. So the antenatal care providers are meant to send mothers for a test in the lab, and along the way we tend to lose the client. Some of them don't go there, the results are lost. So for me, my suggestion is that if we make these test kits available within the antenatal space, it's very possible that every woman who's eligible will have the test done and appropriate intervention taken timely. The other question is the other question has been asked: what do we do for a woman who comes in labor and we do the test and she tests positive? Unfortunately, for such women, from experience, we usually test when we see that.
Sorry, we've lost you again. We've missed an important part of your comments. Okay. Sorry.
Something is not right. It's not right for nurses that there could be something. Then we take the.
So, Patience, your network is it's breaking a lot. I understand from where you're speaking from. We have network challenges. So perhaps you can just finish your comments on the chat. You can just write in the chat box. Before we move on to the next questions, I'll just ask Dr. Mulenga here just to give response to some of the pressing questions that have come up. I think maybe we can attend to those as we continue to think through some of the responses to these questions. Dr. Mulenga, would you like to give response to those specific questions, especially commodity? It's frustrating us in our facilities.
Yeah, so I think the first question that was asked, I believe it's someone from Lusaka district. Let me mention that the approach for implementation is in phases. We have embarked on a phased out approach. Villages have not been neglected. Our aim is to cover the whole country. We are not implementing every site at the same time, and this is a new commodity. It's the first time that we are implementing it in the country, so we need to be learning lesson as we move on. Yes, we have assessed facilities in Lusaka district. We have conducted TOTs in about 5 provinces. Someone speaking from Lundazi Eastern Province is one of the provinces where we have actually conducted the training of trainers. And the approach we want to use is that the provincial trainers will be the one to cascade these trainings to the districts and also to the central level trainers who end at training provincial trainers in facilities. So far, we have trained in 5 provinces: Lusaka, Southern, Eastern, Central, and Copper. The idea is to reach every facility. Let me also comment on where these tests should be utilized from. I emphasized that this is for our pregnant women, and we all understand that the right place for this test is going to be the MCH. But it doesn't mean that it cannot be used anywhere where a pregnant is. And this test is for a pregnant woman and the partner. After doing the provincial TOTs, we will again start with Lusaka. So we are just putting logistics in place to do the on-site orientation, on-site training for the facility healthcare providers before these tests can be used. We do have the SOPs in place. We do have the training package, and only that we have been delayed. We have delayed a bit. Otherwise, as it is now, we should have actually started training in Osaka. And then we'll go out in a phased manner, so that we should be learning lessons. A question on a mother who presents very late, and they are tested almost when they are giving birth. For such a mother, the rule is that if a woman is treated for syphilis 30 days before delivery, you should ensure that the infant is actually treated. And it's a pity that I left out the slide for management of the infant. You need to treat the infant. For a mother who is given treatment for syphilis 30 days or less before delivery. Or if the woman is allergic, that woman does not receive benzathine. Instead, you use mycin and azithromycin and any other drug apart from benzathine. I mentioned that erythromycin and other macrolides will not cross to go and treat the fetus. So for such, we need to ensure that we treat the infants. So we don't use benzathine for infants, please. We use benzoyl penicillin. Aircraft benzoyl penicillin.
Okay, thank you very much. That was quite an exhaustive response. We've taken note of some of the comments in the chat. I think some of them are similar. Please, we want the commodities. That's the comment there.
When I was going to start using you.
Yeah,
Yeah, so we
yeah.
have started the implementation, like I have said. The commodities are in, and we are doing it in the phase.
Yeah, thank you so much. Now we've run out of time. I will just invite quick comments from our experts. Maybe they can just respond to some of these questions that are on this case. Dr. Chimika, then we'll hear from Dr. Moses Akara, then Dr. Adamson Lovo. In that order, maybe you could just quickly make your comments.
Yes, thank you, Chair. So I'll respond to the second question, how should the infant of this mother be treated? So I think from the history, what we got is that this pregnant woman, I'm not sure which gestation age she was, but she so far received 2 doses of benzathine penicillin. And according to WHO guidelines, if a single dose of benzathine penicillin given to a woman who is seroreactive to syphilis 30 days before delivery is adequate to prevent mother-to-child transmission of syphilis. So in this case, as long as this woman at least received a dose. So in this case, she received 2 doses. And if these were given before 30 days before delivery, there's no need to treat the baby. However, this is a baby that we need to closely monitor. In case she develops symptoms, then we can go ahead and test the baby. And if she's reactive to syphilis, then we can treat accordingly. And probably Dr. Priscilla, to be interesting also to take advantage of this, just to comment on some of the myths, especially on the use of benzathine penicillin G as regard to someone having a full stomach. Would you want to comment on that one?
Please go ahead.
Yeah, so this is one of the myths. This is one of the myths that has been going on generation after generation. I don't know how it started. Many times we send these people back because they haven't eaten. So that's a myth. I don't think there's any correlation between having a full stomach and receiving a benzathine jab. So whether somebody has eaten or not, benzathine penicillin jab should be given. Thank you.
Thank you, Dr. Piri, for busting that myth. Dr. Moses, would you like to make a comment?
Yes, thank you very much for this opportunity. I just wanted to quickly mention that we are highly anticipating the triple test, which includes hepatitis. So we're just waiting for it to be WHO pre-qualified. Then we'll see how we can implement it in the country. And then also just to mention that currently we're using ST BioLine Duo to screen for HIV and syphilis. And then we're using one tie to confirm the HIV. We're doing some verification because the recommendation now is that we do 3 tests for HIV. So we're working on a verification study. So we might change a few tests in the algorithm. The algorithm will remain the same, but we might have to change a few tests in there. I think that's what I just wanted to highlight. Thank you.
Thank you very much. Very valuable information there. Dr. Adam from Ndolo, any comments? Okay. Dr. Schembe, would you like to make any comments on, especially on the programmatic end?
Sorry, sorry, I couldn't unmute myself earlier.
Oh, okay.
Yes. So there was a question in the chat box, which was speaking to the seroprevalence of maternal syphilis in Zambia. Maybe speaking a bit to that is that, okay, the problem of syphilis, I think, is something that we still have in Zambia. And if you can quote the Zambia of 2016, the prevalence among adults aged 16 to 49 was at around 6.8%. And a few studies have been done in the country in a few districts which have looked at the seroprevalence among antenatal women, ranging from about 2.7% all the way up to around 12%. So I think with these data at hand, we just need to eliminate dual transmission of syphilis and HIV like yesterday. My contribution, thanks.
Yeah, that's very important. Thank you for putting the numbers to the problem. Yeah, Dr. Wantula. Unfortunately, your sound is not so good. I don't know. There's quite a vibration.
Is this better now?
No.
Okay. Anyway, it's fine. I think
maybe you can just make a comment in the chat. I'll read it. Okay, so we've really run out of time. This is like 5 minutes past 4. And I think to respond to some of these questions, I think answers have been given. I think most in question 1, I think Dr. Priscilla had emphasized on how we want to make sure that every woman is tested. Of course, we do understand the challenge of reagents that have been a challenge within facilities, and we hope as the rollout of the bio testing is continues to move on in phases, we'll have this test available in the various facilities to help us with responding to question 1. Question 2 has been responded to. We as long as the mother received the treatment in good time, a month before, we expect the child to have benefited from treated, but let's be on the lookout. Should we do an RPR test to be repeated? I think we didn't get an answer on this one. Is there a need for an RPR test after once they receive the treatment? Any response to that from the experts? I think we're not too sure whether there was a first RPR was done.
Yeah, maybe I can come in on this one, Dr. Kosi.
Yeah.
Yeah. So what could have happened? I'm not sure if it can be done now. Is that we needed to send sample from this woman who tested positive from the first test for titer. So the titer should be able to guide us whether this is early syphilis or indeed is late. If it's late, then we should be able to give this woman 3 doses of benzathine penicillin. And if it's early, single dose should have been adequate. And in terms of retest, there's no need because I think, as Dr. Mulenga mentioned, this is a rapid test, actually it picks the antibody, so it may still be positive. However, if you, for academic purpose, you want to see if the treatment has been done, of which we don't encourage, you can still do the titer, and the lab should be able to guide you that there's evidence of previous or indeed treatment was actually happened, but there's no need for you to retest since you have treated her adequately.
Thank you for giving us that answer. Dr. Manzi, are you okay with those responses?
Yes, Dr. Ziambo, thank you so much. The responses are very helpful, but I must say that our lab is not able to do titers. So we just look at the fact that the client and our partner have received the treatment, and we should be able to follow up the baby like Dr. Chimika guided. Thank you. My submission.
Thank you so much. Dr. Mulenga? Dr. Sakala, would you like to make a comment on the titers issue?
I think Dr. Chimika has adequately explained. The only, I think, issue we have is that most labs, they're able to do RPR, but some of the technicians or technologists, they don't know how to do the RPR. So maybe we just need to empower them on that.
All right, thank you. So I think that's one of the agenda items that the program probably needs to pick up in oh, it's already been picked up. Thank you. I'll invite Dr. Mulenga just to give her final remarks. I'll come to an end of this session.
Thank you very much for the wonderful, I'll call them wonderful questions. At least they're also helping us to get some feedback. Like I mentioned, we are responding to the challenges on the ground concerning. That's why we are introducing them. We have sung this song for a very long time, but now is the time that the test kits are income and the for Lusaka facility actually in. That is standing in between implementation. Just we are trying to do things effectively so that we can have maximum benefit. So we'll continue mobilizing resources. We are not guaranteeing that we have a basket somewhere that is about mobilizing. Even these kits that we have we have had to mobilize, and that will continue because we all want to ensure that we eliminate mother-to-child syphilis in our population. Thank you very much. I think we are going to add the slide management of congenital syphilis, which I think we did not include. Yeah.
Thank you very
Thank you
much.
very much.
It's been a very productive session. So thank you very much to all that joined in, and we look forward to seeing you again next week. And we'll have another interesting session, and we'll call it a wrap, and good day.